Hello everyone, it's me Dr. Ayaz Ahmed. I am working as an aesthetic dermatologist. So today I will cover another important topic of dermatology. The name of topic is clinical presentation of dermatomyositis. In this section I will cover muscle sign. So number one muscle sign is the proximal muscle myopathy. These patients usually complain of difficulty to comb hair and getting out of chairs and climbing stairs. Second clinical presentation is the sudden weakness, respiratory compromise and weakness and aspiration. And third clinical presentation is the interstitial lung disease in about 20 to 40% of cases according to IIM series. These patients present with dry cough, exertional dysphonia and crepitations of lung. Fourth presentation is the dysphagia, immunosuppression, mild rhythmic disturbance and arthritis. Clinical variants of dermatomyositis. So there are lots of clinical variants. These include overlap syndrome, anti-synthetase syndrome, juvenile dermatomyositis, clinically amyopathic dermatomyositis, drug-induced dermatomyositis. Differential diagnosis of cutaneous sign of dermatomyositis. So these include lupus erythematosus, seborrheic dermatitis, rosacea, allergic contact dermatitis, psoriasis, lichen planus, lichenoid drug eruption, cutaneous T-cell lymphoma. These all diseases they must be differentiated from cutaneous sign of dermatomyositis. Investigation. The number one investigation is the measurement of muscle enzyme. The measurement of muscle enzyme, especially creatine kinase or CK and other muscle enzyme in blood is mandatory. The measurement of enzyme indicates the muscle damage or inflammation. Autoantibodies. The testing for specific autoantibodies, example anti-Jo1 antibody, anti-Mi2 antibody, aids in diagnosis and help predict the disease course. Third investigation is the electromyography, EMG, assessment of electrical activity in muscle by using electrodes is involved. It identifies characteristics pattern of muscle fiber involvement. Fourth is the muscle biopsy. In muscle biopsy, removal and examination of a small muscle tissue sample is required. It identifies or reveals inflammatory changes typical of dermatomyositis. Another important investigation is the imaging studies. It includes MRI that detects muscle inflammation and edema, X-ray chest that assess for lung involvement. Final investigation is the skin biopsy that sometimes performed to confirm the presence of characteristics skin changes associated with dermatomyositis. So now let's come to the management. The management include pulsed IV methylprednisolone. UL dose is about 0.5 to 1 gram per day on 3 consecutive days for severe life-threatening disease, followed by oral prednisolone 0.5 to 1 milligram per kg per day. Disease-modifying anti-rheumatic drugs after pulsed methylprednisolone such as methotrexate, azithromycin or cyclosporine are given. Here note that whenever patient is suffering from interstitial lung disease, so avoid methotrexate because it can exacerbate the condition. Consider IV immunoglobulin particularly if the patient has dysphagia. Alternative regimen include pulsed IV methylprednisolone 0.5 to 1 gram per day on 3 consecutive days for severe life-threatening disease, followed by IV cyclophosphamide for severe life-threatening disease. Pulsed prednisolone 1 mg per kg per day. Third treatment option is the DMARD after cyclophosphamide such as methotrexate, azithromycin or cyclosporine. Consider IV immunoglobulin particularly if the patient has dysphagia. Second line options is the mycophenolate mofetil or oral tacrolimus. For skin limited disease, go for potent topical corticosteroid ointment or topical tacrolimus 0.1% ointment plus hydroxychloroquine plus or minus mepacrine. Third line option is the rituximab. Thank you very much. Stay connected and subscribe my YouTube channel.